I'll go on to our last speaker who's going to teach us how to remain premium in corneal surgeries. Is Dr. Pravin Krishna, who's going to be talking on post-keratoplasty astigmatism management. Dr. Pravin, could you share your screen? He's the director and heads the cornea, cataract, and anterior segment services at LV Prasad, winner of some of the most prestigious awards in India and abroad, innumerable publications, and a major presence nationally and internationally, and a teacher par excellence. So let's hear from Dr. Pravin.
Thanks a lot, Chitra, and congratulations to you and the ARC for actually putting together a course on keratoplasty. I think very pertinent and very apt topic for the postgraduate students who have had an overdose of cataract and refractive surgery, I think. So thank you. After listening to all the wonderful talks that you've heard today about managing and doing the perfect surgery in different situations, after you've done a keratoplasty, one of the things that all of us would be confronted with is astigmatism after doing either a penetrating keratoplasty or doing a dark. So what I'm going to cover today in the next 15 minutes or so, what are the factors that influence astigmatism either during surgery or right after surgery? What do you do to minimize astigmatism during surgery? And very briefly about correcting high astigmatism once you already have significant astigmatism. And I'd like to actually say that initially when you start doing keratoplasty, the thought process is you want to achieve a clear graft. And you have a clear graft, most of us are pretty happy. But that is like thinking like a retina surgeon. You have a retina that's attached and you're happy, but the patient is not. I think you need to think like a refractive surgeon when you're doing a penetrating keratoplasty or a DALC, because you want to give the best possible vision to your patient. So here is an example of a patient who has macular dystrophy who underwent a penetrating keratoplasty. And you'll see that this patient has a wonderfully clear graft, very clear, and you'll see that he's had a cataract surgery as well, all sutures out except for one broken suture here. And this patient actually has a vision of 20 by 20 with a correction of 0.75 and 0.75, non-toric IOL in the eye. So what does it take to actually achieve an outcome like this in all keratoplasties? Now here is another patient who had a DALC surgery. But then let's take a break to look at the factors that affect astigmatism in the eye. Now, the factors that affect astigmatism are surgical, they're patient-related, as well as post-operative. We'll focus on the surgical factors. So here is another patient who's had a keratoplasty, and you'll see that this is, again, a very beautiful graft to look at. Very nice sutures, everything in place. And this patient has very good vision as well. This is early post-operative. And this patient has a vision of 20 by 25 with a relatively low refractive correction. Now, if you contrast that with another patient, here is another picture of a very clear graft. Again, early post-op, about 3 months or so. And you'll see that this patient has a hyperopic error with a cylinder and is not correcting beyond 20 by 60. So what is the difference between the first patient that you saw and the second patient that you're seeing right now? Well, if you try and look at the difference between these two grafts, both are clear, but the difference is the fact that when you look at the centration of the first graft, you'll see that it is very well centered on the pupil or on the visual axis as a corollary. In the second patient, you'll see that the centration is nearly not as good, and that is one of the major factors influencing the outcome of keratoplasty. Now, when you also look at the other factors, including suture length and distance of the suture from the visual axis, you'll also see that in the first patient, the sutures are uniformly spaced away from the pupil. But in the second patient, you'll see that some of the sutures are long, like you see up here, and some come very close to the visual axis, which is again the reason why this patient does not have very good vision. So centration, how do you achieve good centration? You can use a number of techniques. But all you have to do is ensure that you center your graft on your cornea. A lot of times there is parallax, especially in cases of keratoconus. So you need to ensure that you mark the cornea and mark the center as well, either with ink or maybe with just a simple technique by using a Sinskey hook to ensure that whenever you start to trephine, you're very well centered on the cornea. This is just marking the center And once I mark the center, then you use your Trifine, whichever kind of Trifine, you'll see that the centration is exceptionally good in a case like this, and you can expect a good visual outcome in such cases. Now, the reason why centration is important is if you overlay topography on this corneal graft, you'll see that the sutures that are there on the right side are causing quite a lot of flattening because they're close to the visual axis. And because of this patient is going to have a poor visual outcome. So it's very important to ensure that your sutures are uniformly distant from your pupil, and that is what is going to determine your centration and your visual acuity as well. Now, coming to graft sizing, again, in our residency, we've been taught that we should do the smallest sized graft possible. Well, this is wrong. Here is a patient of keratoconus who had to undergo a very large graft because of some peripheral thinning as well. And this patient is post-operative 1 month, 1 week, and you'll see that his visual acuity already unaided is 20/40. And the same patient at 1 year with hardly any of the sutures removed now has a visual acuity of 20/20 with a correction of just -2 in that eye and no astigmatism. Now, another reason why this is happening is not because the surgeon is exceptionally good, but because of the fact that the sutures are very far away from the pupil. And that's the reason why a large graft in several cases is better than a small graft. Not that you have to do as large a graft as possible, but the optimum minimum diameter seems to be about 8 or 8.25 now to achieve this kind of visual acuity. But what do you do when you have sutures that are tight? So if you have sutures that are tight and these sutures can be removed, you see this is a patient who has astigmatism of almost 10 diopters, vision 20/250. You remove 4 sutures, astigmatism comes down to about 5, and then you remove a couple more sutures, and then the astigmatism comes down to 3.5, and the patient has 20/25. So tight sutures during surgery are also a major factor in influencing the amount of astigmatism in the eye. Now, here's another patient of keratoconus before surgery, pretty poor vision, 20/320. He undergoes keratoplasty, and then we've tried to remove sutures by managing the astigmatism. But at the 2 months post-op visit, he has 16 diopters of astigmatism. After suture removal, he has 10.7 diopters, and more sutures, still about 10 diopters. And 7 months post-op, still about 10 diopters. Now, there's something wrong in a patient like this, and you need to examine the host bed carefully. If you see this patient's host bed, you'll see that the entire cone has not been excised. So it's not just sutures. You also need to ensure that you remove the entire pathology to ensure that you can control your astigmatism as well. Now, what about the type of sutures? Here again is a patient with a large cone with keratoconus before surgery. And this is the same patient 1 month post-op with a refractive error of 2.5 and -0.5 cylinder at 130. And this patient has continuous sutures, which again, I like a lot because they seem to give very early stabilization of refractive error as well as visual acuity. And this patient is 20/20 with a low correction in the early post-op period. That's his topography, very regular topography as well. Another important aspect of suturing is graft hose apposition. If you look at this graft and you look at the different parts of the graft hose junction on the OCT, you'll see that there are some areas which are really well apposed and some that are not really well apposed. For example, you'll see there is some amount of gape in the posterior part of this graft hose junction. And if you compare that with another patient who has interrupted sutures, look inferiorly, there are some loose sutures, some short sutures, and you look at the astigmatism in this patient, 15 diopters against the rule. And if you look at the OCT of this patient, you'll see that the OCT shows that the graft hose junction is really not very well apposed, which actually explains why this patient has such high astigmatism. So graft hose junctions that are well apposed are like the one in the top picture, where you have a good anterior apposition. Ones that are poorly apposed are like in the bottom picture, where you see that there is quite a bit of override of the host bed. Poor apposition also leads to loose sutures and also leads to ectasia of the graft hose junction, like you see here. And this results in elevation of the graft, as you can see on the topography, and a flattening of that area of the graft. Now, this is seen on OCT as well as this area of elevation, and this needs to be corrected not by removing sutures, but by putting sutures. And one of the important determinant of having good apposition of your graft by sutures that last long are to ensure that you get good suture depth. What is taught in books is to go to about 80 or 90% of your graft as well as your host bed, so that you have good apposition and you have uniform tightness of your sutures when you apply your sutures. Now, similarly, sometimes after removing sutures, you have ectasia of the graft host junction. This needs to be repaired. As you can see, preoperatively, there is ectasia on the left side. Postoperatively, after repair, the topography is almost normalized and looks much better. So that's another reason why continuous sutures along with interrupted sutures seem to be a good bet, because they provide a lot more areas of compression. And that's why you have early stabilization of astigmatism in these kind of patients. This is the topography from the previous patient showing you a very nice topography. So what do you do when you have high astigmatism post-keratoplasty? There are a number of methods, but I'll very briefly touch upon 3 important methods after keratoplasty. This is a patient who had astigmatism post-keratoplasty, had an IOL in the eye already. So we did a relaxing incision and a compression sutures. This is an incision that is made inside the graft host junction. And this patient did really well at 1 month, where he had astigmatism come down to only 1.5 and his vision was 20/25. If you have very high astigmatism, like in this patient, very high against rule astigmatism, almost 11 diopters, you can do a toric IOL or a toric phakic IOL. This patient ended up with 20/30 vision after a toric IOL inside the eye, because she also had a PSC in the eye. Similarly, one of the other methods that you can use, this is an eye trace that shows that the internal astigmatism is cancelling out the corneal astigmatism very nicely in this patient. Another method that you can use is also to do a surface ablation. This is a post-DALC surgery where we did a PRK for a patient who had a -5.5 astigmatism, vision improving only to 20/25. Topo-guided PRK in the same patient gave him a 20/20 vision with a lower amount of cylinder that he could wear glasses in. So to summarize, the factors that affect astigmatism that we saw so far are mainly surgical, centration, suture length, the size of your graft, the host bed, kind of sutures you use, the graft host junction, apposition, and a number of other factors. But there are 3 things that you must remember when you're doing keratoplasty: that most of your astigmatism comes from the time of surgery, not after surgery. So you need to put in as much effort as possible to reduce or minimize this during surgery. If you have an elevated graft host junction or high astigmatism that you can't control, you need to decide between removing sutures versus applying sutures, because both are equally effective in the individual cases. If all sutures are out and you have high astigmatism, you can use relaxing incisions, you can use PRK, or you can use toric IOLs to correct this astigmatism. So thank you very much again for the opportunity. And I hope you remember those 3 take-home points.
Oh, that was an excellent teaching video. I mean, I don't think I'll forget a single sentence that you spoke today. How effective are these topo-guided PRKs on these post-graft corneas?
Most times it seems that topo-guided PRKs, at least I reserve them for DALC. I do very rarely for post-PKIs. They seem to be a 2-step procedure rather than a single-step procedure. So most patients, if they're willing for 2 steps, I do it as a 2-step. If not, I just do a wavefront optimized single-step PRK, because that does not result in an increase in myopia. But quite effective, very effective.
Dr. Rajesh, you have some questions to ask? Dr. Rajesh Fogla.
I think Pravin has given a very structured talk and he has covered most of the points. And I think what I liked was the relevance to the surgical technique, because that's the most important step in preventing astigmatism. Management is definitely also challenging as well, but I think if you can prevent the astigmatism, that would go a long way. We can ask Dr. Titial. I think they have done ALTK also by making a flap first, and then you have done the LASIK later on, and the flap has also reduced the astigmatism in post-keratoplasty eyes.
I think, Dr. Namrata will be the right person to answer this.
Oh, okay.
So I think we've described 2-step technique, where in first step 1, we've just lifted the flap and left it like this, and put it back. And then 6 to 8 weeks later, we again relift the flap, because when you make a flap, then also some of the tension lines are relaxed. And that also acts like a keratotomy and kind of decreases the astigmatism. So that takes care of about 2 to 4 diopters of the cylinder, and then whatever residual is left, you can relift the flap and correct it after doing LASIK on it.
What flap thickness did you prefer to use for such cases?
We prefer to go a little deeper, and we prefer to go because you are trying to relax the tension lines which are at the graft host junction. So more than the depth, it is the size of the flap that is more important. So you try to encompass that also. So you go in for larger flaps, and they have to be a little deeper, otherwise it will not cause the relief of the stress lines.
In that study, we had taken a 9.5 millimeter suction ring and 160 microns flap, if I remember correctly. And the average correction just by flap creation was 2.48 with a standard deviation of, I think, 1.25 or something.
We
Do you
missed out on that talk on during COVID era, the challenges of doing a corneal graft, corneal enucleation. Yeah.
All of us are having challenges.
No.
By banking in
The
the
question is, if a person appears to die a natural death, so would you take those extra precautions, do a COVID test along with the other battery of blood investigations? How would you deal with those situations?
So, Dr. Tityal, sir, would you like to answer that, sir? Yeah, for the protocol that we follow at our center and the protocol that is followed everywhere else is a little different.
Yeah,
Sir?
that's true. I think we in AIMS we have put a policy now to get a RT-PCR sample from the donor nasal pharynx. We do RT-PCR, and after that we, as such, we have to keep the tissue for at least 40 hours, 48 hours in the medium. So that gives enough opportunity to get a RT-PCR test done, a result, and we do all other tests also, and that is just now it is implemented, and I'm sure in next few months, if the cases go down like which is happening in the country, maybe that may not be required.
As per the directive of the Ministry of Health and Family Welfare, it just says you can retrieve the eyes taking adequate precautions. It doesn't say that RT-PCR is mandatory.
Dr. Rajesh, you have any other question to ask before we conclude?
No,
Dr.
just
Maipal sir,
Yeah.
Dr. Maipal sir would like to say something, sir?
No, I am a wrong person for this symposium, so I just listened and refreshed my memories because it's been quite some time since I did a graft. But obviously, there have been a lot of revolutions that have happened in corneal surgery, and the outcomes have become much better. So I think all these speakers did great justice to it, and the partial thickness or the breaking up into the various layers is the greatest innovation, I would say, over the last decade happened, and obviously has reduced the incidence of rejection and has improved the outcomes. Regarding the corneal eye bank donation, I think what is very important today is that it was stopped the home retrieval, and most of you might be aware that it's only with the effort of Namrata, I would say, as also the Eye Bank Association, AIOS, the Cornea Society, etc., that we represented, and now the home retrieval has been re-allowed by the government. So I think the testing of RT-PCR or RAT or whatever has not been, as Namrata rightly pointed out, has not been said anything by the government. So I think it will be an individual thing whether one wants to do that or not, depending upon how the patient, like what is the reason for the death of the patient. More often than not, I think people who have unnatural deaths or something, they might be undergoing a COVID test because the number of tests, at least in Delhi, are almost about a lakh a day. So I think lots and lots of people have got that done, especially those who get hospitalized. So that is regarding the grafting part that you asked about the eye banking. But I think the numbers have gone down dramatically. I think I may be corrected, but in the last 6 months, the retrieval is down to 30%, I suppose, of last year.
Yes, sir.
Yeah, so that is the kind of impact that COVID has had as regards the availability of the corneas and the number of surgeries that have been done. So I think with the other things picking up all over India, I think most of us are back to about 80-90% of our practices or to this thing. But the corneal grafting is still I think lacking, and maybe it would be picking up soon. So that's what I wish to add.
Thanks, Dr. Mahipal. Dr. Rajesh, anything else to add?
I think also we need to look at with the lamellar surgery, tissue utilization can be improved. You can use a single tissue for doing a DMEC and DALC as well. So that's again optimal utilization of tissue when your collection is less. Maybe even the DSEC lenticule, when the anterior cap which is there, instead of discarding it, it can be preserved and it can be further used. So I think we have to look at ways and means of optimizing tissue utilization at the eye bank when the collection is lower, especially for dealing with infections, perforations, where if because of lack of donor tissue, sometimes the management becomes quite difficult.
Any other important question was left unasked? Panelists?
Just wanted to ask Pravin, any modification do you do when you do a PRK on a grafted eye in terms of using intraoperative mitomycin C or postoperative duration of topical steroids? Because often it's seen that these eyes, maybe sometimes the tendency for haze formation is a little more compared to virgin eyes.
Yeah, I do a specular and then I do a 2-minute exposure of mitomycin C on these eyes, irrespective of the amount of ablation. So that seems to work pretty well.
Dr. Any thoughts? Just this thing. How would SMILE work on post-PK astigmatism?
No. That opens up a whole new.
Maybe you could try and write something about it. I don't know.
But anyway, the major challenge is the astigmatism in these cornea. So a SMILE, I don't think really corrects too high astigmatisms.
But sometimes
up to 6, but the only thing is that even if there is a residual refractive error or myopia when an astigmatism, I was just wondering how it will work. That's.
So I think I'll conclude then. It's been an amazing webinar with real experts on the expert panel who gave the inputs, and we seem to have discussed all the relevant aspects with leading line of speakers too. Special thanks to one and all of you in this audience. My thanks to my co-moderator, Dr. Rajesh Hogla, who should have actually been one of the speakers and we could have gained even more from him. Paucity of time, there was only this many questions we could ask. My thanks to my very able ARC team, and it's so nice to see them here till the end of the show because many of us are not too connected to cornea. My thanks to AIOS admin led by Mr. Kripal and his entire team. Mr. Sunil, who actually is the administrator of the webinars and has been doing a great job over this year. Sai and Manjula from Numerotech for steering us through our ARC works. My immense thanks is due to the Entode group under Mr. Nikhil, who have been our major sponsors, rather main only sponsor for all the educative activities of ARC. My deep felt thanks to them. And my thanks are due to our dear attendees. There have been quite a few of them in spite of the festival time. And thanks for all your support, which helps us scale newer heights. Thank you, one and all of you. Thanks a lot.
Thank you, Rachitra.
Thank you.